Hi everyone, so yeah, my name's Laura and I'm going to be talking to you today about triaging patients. So we'll start off just by talking about what triage means. So triage can be defined as the rapid evaluation of a patient's needs and providing care to the patients in order of urgency, and that's by prioritizing treatment to the most serious problem first. So basically, we're just sorting our patients and the treatments into the order that we need them. Triage can be performed over the telephone when they present to the clinic and also in the hospital situation itself. So starting off with some telephone triage. This is going to be the first contact that the clients have with us at the clinic. And when it isn't an emergency or they feel it's an emergency, they're really stressed, can be really hyper emotional as well. So it's really important to stay calm, confident and clear with all communication. And the aim of the conversation is going to be to determine whether the patient needs to see a vet immediately or whether it can wait until an appropriate consult time. So always start off by just asking why they are concerned about their pet, what's the reason that they're calling. Just confirm signalment, so that's your age, breed and sex of the animal. And with the rest of the information, it's a good idea just to get to use direct questions so that you're going to get direct answers. So they tend not to go off on such like a tangent then. So you can ask things like, does the patient walk? Is it eating? Has it vomited? And that'll give you the basic information that you need from that. So when you're actually advising your clients, you need to be very clear and definitive with the advice that you're giving. Again, they will be stressed. Sometimes it takes a couple of goes to actually get the information into them. And if there's any indication of a compromised major body system, so for example, breathing difficulties, if they're unconscious, collapsed or actively seizuring, then you need to be very clear that they need to be seen by a vet immediately. It's a good idea when you're on the phone to them to ask the clients to bring any medications that the patient might be on with you so that you can see dosages. And also if they talk about possibly or they have eaten a toxin, if they can just grab that packaging and bring that with them, that means we've got all the active ingredients in front of us. Just a reminder, we are nurses and we can never diagnose anything, but especially over the phone, you don't have the patient there in front of you. So a lot of clients will want you to diagnose, but it's really important that we don't do that over the phone. And you might need to give some advice to the clients on how to transport the patient safely to the clinic. So that can be something as simple as if it's actively seizuring, that you advise them that their dog or cat doesn't know what's going on and there is a danger that they might accidentally get bitten, to use a towel to pick them up, keep them nice and cool in aircon if they're having breathing problems, things like that. And once you come off the phone, you can use that telephone triage as a source of preparation for us in the clinic. So it means we can let all the other staff know what is coming down and also prepare things like oxygen and IV catheters if we need to. So moving on to the initial triage stage, that's when they come into the clinic. So again, you want to greet them immediately and always still have that calmness, confidence, and be clear with your instructions. And you also want to introduce yourself, unless it's a client that is with you guys in GP a lot. They're not always going to know who they're talking to. So I would always introduce myself as a nurse. They don't mistake me as a vet. And also for the vets, they would introduce themselves. So your initial assessment is going to take place in reception, and it shouldn't take any longer than 60 to 90 seconds. It's just a very quick overview of what's going on and to identify the immediate problems. That's going to decide the urgency of the case and how to proceed only. So you're only going to take a capsule history. You only need limited information at this point. They'll talk to the vets about a full history. You're going to just confirm your signalment, what the problem is, any possible causes, the duration of the problem, and just confirm again any current conditions that the patient's dealing with and medications that they might be on. So then you're going to observe the patient and carry out a very basic examination, which you're just going to base on the 3 major body systems, so neurological, respiratory, and cardiovascular. Okay, so this slide is just to show us that as nurses, it's really important that we know our normals. So this is just a table here which has all the rough normals for both dogs and cats. And that means if we're confident with knowing these, we'll be able to identify when something is abnormal. So first of all, just assessing the neurological status. So I normally do this as I see them walking in the door, and you're going to make these assessments as the patient comes towards you. So are they bright and alert? Is the dog, are they able to walk in, or were they carried? Were they collapsed when they were brought in? Dragging any limbs? That's going to give you a basic overview of the neurological status. If there is anything that the owner flags up that they know that it has had a seizure, possible head trauma, then you might need to take it one tiny step further and just check the pupils, check the size, symmetry, and check the pupillary light reflex as well, just to see if there's anything abnormal there. Moving on to the respiratory system, again, I do this as I'm talking to the owner and I'm looking at the patient and just watching the way that they breathe. So are they breathing? Is their airway clear? Just do a quick count of the respiration rate. Should be between 10 and 30 breaths per minute. This can be a little bit elevated when you're in an emergency centre because the animals are stressed. But if they are a little bit tachypneic, then the main thing is to make sure that their effort is normal. So do they have abdominal effort? Is it really shallow breathing? Also, you can look at their body language. For dogs, if they've got their neck extended, their elbows abducted, nostril flared, then they're having some serious trouble there. You can have a look at the mucous membranes. For any animal that's dyspneic, normally they're panting, even cats, so you can quite easily see the mucous membranes and see the tongue to check the colour. And then lastly, moving on to the cardiovascular system. Again, this is just a very quick check. Check the mucous membranes, should be nice and pink and moist. Capillary refill time should be 1 to 2 seconds. And just know your heart rate, so 80 to 140 beats per minute in dogs and 180 to 220 beats per minute in cats. Again, might be a little bit elevated because of the stress, but they should be round about that. And you don't even need a stethoscope to do this. I will quite often do this when I'm just leaning down to say hello to the pet, and the owners might be talking to me directly, but I'm just having a feel of that pulse. And that way that you can just check if it's normal or whether it's weak or bounding. And just that 60, 90 seconds that you take to get that information is then going to lead you on to be able to categorize those patients and put them in a triage level. So there's a range of different triage systems. They all have the same purpose. The ones that I'm going to take you through here use a form of numbers and categories, and it's based on the Manchester triage system. So some examples of level 1 are dyspnea, collapse or unresponsive patients, severe shock, active seizuring, heat stroke, if they've got severe hemorrhage, if there's a possible or known snake bite, abdominal distension and anaphylaxis. If one of these comes in, just inform the client that you need to take the pet straight out to see a vet for stabilization, and that the vet will come out and discuss with them as soon as possible. It's also a good idea at that stage to just, while you're taking the pet from the owner, just to confirm that they are happy for you to pop an IV catheter in and to give any emergency drugs. So if the patient's dyspneic, they need to be provided with oxygen immediately. Be done whichever way is easier for. It can be a bit stressful trying to force a mask on, so it might be easier to do flow by, or ideally if you've got an oxygen box, then just pop there. If the patient's actively seizuring, then it needs to get some anticonvulsant drugs in there as soon as possible. So ideally, if you can get an IV catheter in there. When you're doing that, if you have a handheld glucometer, and you can, and it might require active cooling at that stage. And then following on from that, if you've got a heat stroke patient, it will require active cooling. If you've got a hypovolemic patient, they're going to need fluid resuscitation as soon as possible. So moving on from level 1 to a level 2, which is classed as urgent. These ideally would be assessed by a vet within 10 minutes of the initial triage. Examples of this is hemorrhage that has been controlled, fractures, trauma, toxins, dystocia, urinary obstruction. If you've got a sick diabetic, generalized weakness, severe dehydration, and shock. So this class is a bit harder to assess. Sometimes you need a little bit more information. So if they're just borderline and you're not too sure, then you can take them into a consult room and just get a few more vitals just to kind of confirm. So that's when you could possibly use your pulse ox to get an SpO2, get a temperature, and possibly a blood pressure reading as well. That's then going to tell you if anything's abnormal on that, you might need to bump them up to a level 1, or you might be happy that everything else is looking okay and you can leave them in the waiting room for that 10 minutes. These patients are always at a high risk of decompensation. That can happen at any point. So if there is a delay with your vet getting out to see them, then I would just re-triage at that 10-minute point, retake all those vitals really quickly and just make sure there's no changes and things aren't worsening. And if in doubt with these ones, while you're getting used to things, definitely just level them up. Better to be safe than sorry. And then we've got level 3, which we class as serious. So these patients, ideally, we would see within 30 minutes of presentation to the clinic, but they're suitable to wait in the waiting room. So examples of this are your acute spinal case, patients with head tilts, large skin wounds, acute coughing, melena, vomiting, if they've got moderate pain, if they have some mild facial swelling but there's no sign of anaphylaxis, blood in urine, and moderate dehydration. So these patients aren't at immediate risk, but potentially they can also decompensate. So you do need to regularly check on them in the waiting room and recognise if there's any changes going on, and you might need to reassess the level at that stage. And last of all, we've got our level 4s, which are our routine consultations. So these ones are deemed stable, and they can wait until a vet is available to do a full consultation with them. Examples of this are skin and ear issues, weight-bearing lameness, if it's got a very minor skin wound. They might have had a single seizure, but the patient is completely back to normal. Mild pyrexia, GI signs, but there's no dehydration at the moment. And we can't forget that triage in the hospital setting is also really important, especially with us in ICU. This is a huge role of us as the nurses. Inpatients should be regularly assessed and vitals taken and also recorded whilst in the hospital. Doing this means that nurses are constantly triaging, and if any patient decompensates, then we can then get treatment for them as soon as possible. And this means that we can then alert the vet and they're going to be prioritized by the vet. They don't always have hands-on kind of time with all of the patients, especially here where we've got a really busy hospital. So they do rely on us picking up when something is changing. So our three big take-home points today is that triage means to sort. It's quick and simple observations and examinations on the patients, meaning we can place them into a triage level where the most urgent cases will be seen and attended to first. Learning to recognise those critical patients, meaning that they can be prioritised. This is really important, and all of your observations will actually save lives. And to constantly reassess your waiting room and your hospital, so that if there's any patients that do decompensate, you're going to alert the vet and that patient's going to get treatment rather than that going unseen. So I've just got a couple of quick case studies to go through of patients that have come into us here. So first one is Archer. He's a 9-year-old male neutered Labrador. So he presented, the owner phoned up and said he'd found his dog collapsed at home. So we told him to come in. So capsule history was that he had intermittent vomiting for 1 week and inappetence for 24 hours. So when he was brought in, it was noted that he was carried in. Now, a good trick that I use as well is when they're carried in, I always ask them to pop them down on the scales. That way, we need the weight anyway, so you're getting important information. But it means that when they're put down on the scales, you'll then be able to see whether they can move on their own, and the owner is just carrying them because they want to, or whether they can't get up. So in Archer's case, when he was put down on the scales, he was able to lift his head, but he couldn't stand on his own. With his respiratory system, he was tachypneic. His rest rate was 44 breaths per minute, but he didn't have any effort at that point. And his cardiovascular system, his mucous membranes were pale. His heart rate was 180. And also when we went to feel a peripheral pulse, there was no pulse there. So thinking about what level we should class Archer as, so we classed him as a level 1. He was in hypovolemic shock. He was really hypoperfused and he needed those fluids as soon as possible. So he was prioritized in this situation. And then he did end up having emergency surgery because he had swallowed a large football sock and it was a linear foreign body with septic peritonitis as well. And last of all, our second case study. So this is Rosie. She was a 2-year-old female neutered Maltese. So when the owner called this time, she was really highly distressed, telling us that Rosie had been attacked in the park and had very large wounds and they were bleeding non-stop. So when she came into the practice, she again carried Rosie in her arms, put her down on the scales, and Rosie walked off them without any issue. She did have an obvious wound on her limb, and it had blood around it, but it wasn't actively hemorrhaging. And she was able to put some weight on that leg. So in this situation, the owner was a lot more distressed than Rosie was. Respiratory-wise, she was panting, but there was no effort, and her mucous membranes were really nice and pink, so there was no signs of cyanosis. Cardiovascularly, her heart rate was 140, mucous membranes were nice and pink, CRT was less than 2 seconds, and her pulses felt completely normal. So thinking about what level we should class Rosie as. So we classed her as a level 3. So she was serious. There wasn't any current compromisation of any of the body systems. But she did need some treatment for that wound. She needed some pain relief. She was quite sore, but she wasn't in that immediate danger, so she could wait, and any other level 1s or 2s could be prioritized before her. But even with cases like Rosie, we can always remember that things can change at any moment. We haven't done a full clinical exam over those patients, so there could be something that we haven't picked up on yet. So always re-triage as necessary. And that's the end.